As Marcos mentioned, I am Marcy Nielsen. I'm the CEO at the Patient-Centered Primary Care Collaborative, and we're thrilled to have you joining us today. We are also thrilled to have Elaine Ryan, who is the Vice President of State Advocacy and Strategy Integration in the Department of Government Affairs at AARP, joining us. As I think you all are well aware, today is an exciting day. We're going to be hearing about some terrific opportunities that I think this country has in terms of supporting caregivers, but we do want to give a shout out to the Supreme Court ruling just this morning on the Affordable Care Act. As many of you know, we have been waiting with bated breath, and the decision today, 6-3 in favor of the Affordable Care Act and the provision of subsidies to those who qualify. It is very important to people all over the country who rely on those subsidies to be able to buy health insurance. That topic is, of course, near and dear to many of our hearts, and it's just one piece of providing access to people who are suffering from debilitating illness. The role of caregivers and families in providing care to people who are in and out of the hospital, in and out of long-term care settings, in and out of primary care settings, is one that unfortunately far too many people in this country face. And it's something that until you have a loved one who is ill, you are often not aware of. AARP, as one of the nation's largest and most influential advocacy organizations on behalf of Americans age 50 and older, has taken up this incredibly important issue, as we have individuals in this country, 10,000 of them every day, turning 65 and older. The population of individuals who is aging is going to fast overtake the number of workers, and that includes caregivers. So we need to be very mindful of how we support the caregivers who are taking care of this nation's ill and disabled populations. And with that, I'm going to quickly introduce Elaine and turn this over to her, who's going to tell you about what they're doing at AARP to support family caregivers. So as I'd mentioned, Elaine's the Vice President of State Advocacy and Strategy Integration, the Department of Government Affairs at AARP. She leads a team of legislative staff who work with the 53 different AARP offices all across the country. And she pushes that agenda with governors and state legislators to support, as I mentioned, those individuals over the age of 50 and their families to ensure both long-term financial security as well as health security. Elaine has a very illustrious career working on behalf of patients and their families. She's worked on a number of important legislative victories, and she has spent a number of years in the state of the great state of New York, I should mention, hailing from upstate New York. She served in a number of roles working for various U.S. members of Congress, the New York State Governor, as well as working on behalf of the American Public Human Services Association. She has a background in public administration with a degree from the Kennedy School at Harvard, as well as an undergraduate degree in economics from Fordham University. We are so thrilled that Elaine is with us today to tell us about the important role of caregivers. And with that, Elaine, I'm going to turn it over to you.
Thank you so much, Marcy, and it's so great to be with you and have the opportunity to talk about our work on family caregivers. And I would be remiss if I didn't chime in and say how thrilled we are at AARP to see the Supreme Court decision. Since the Affordable Care Act has been implemented, we've seen a 31% decrease in the number of uninsured individuals aged 50 to 64 in this country. So a lot was at stake for those and millions of others who gained their first access to health care for many with the Affordable Care Act. And so today we want to talk a little bit about our work at AARP on supporting family caregivers. You should know that ARP has made this a organizational priority. Our new CEO, Joanne Jenkins, has put this on our organization-wide dashboard because it's an issue that spans so many people's lives. And beyond just the work that I'm talking about today, I just want to note that I was a family caregiver for my mom and pop for more than 15 years. So we saw it all. Once you see that system up close, you realize it's not a system at all. The bumper sticker that I have hanging in my office is long-term care, fix it before I need it. Because, of course, we've got to do better than this. So today, I just want to talk a little bit about a background of who are family caregivers. You know, most people don't identify themselves. When you say caregiver, they say that's not me. They view themselves as a son or daughter, a brother or sister, a partner, a friend, a neighbor. But as ARP has gone through and identified those self-identified family caregivers, we found that in survey after survey, the average U.S. caregiver is a female, about 49 years of age, and also working outside of the home, but spends nearly 20 hours a week. '09 survey, we found that 42 million Americans identify themselves as family caregivers. And our Public Policy Institute has estimated in a report called Valuing the Invaluable that if you were to pay those family caregivers for the care that they deliver every year, it would exceed $450 billion a year in unpaid care to their loved ones. You know, just to put that in perspective, that's more than the total amount this country spends on Medicaid. And it's a significant accomplishment or contribution that, frankly, few people recognize. That's why some those in the media have described family caregivers as hidden heroes. They're invisible parts of our healthcare system, but some would argue perhaps the greatest part of our healthcare system. We found that about 74% of family caregivers have worked at some time during their caregiving experience, and 58% are employed currently either full or part-time. And when you think about it, they're not only working 40 hours a week or more, then they're putting an extra 20 hours a week in care for their loved ones. The employed caregivers have become a huge focus for us because of the fact that many laws in the states do not cover those employees. There's no paid sick leave for part-time workers, and nationally about half of the people who go to work every day have no access to paid or unpaid sick leave, which is pretty amazing when you think about how families are juggling, often trying to choose between taking their mom or dad to a doctor's appointment or losing their job. The other piece that I'll talk a little bit about here that our survey found was that family caregivers take on a huge and different array of responsibilities on behalf of their loved ones. And that can be anywhere from financial management to medication management to scheduling appointments to retrofitting their homes to shouldering the burden that often is, as my experience was, it was a little joy, it was a little burden, but at the same time, it does create a real stressful a situation for family caregivers, and we know that the biggest deterioration of health that we've seen in our surveys take place is of family caregivers who really take their own health for granted, miss doctor's appointments, don't take care of their own health needs because they're so focused on the care of their loved ones. The work that we are currently moving in states across the country, and this has been an exciting year for us. We have our 50 state offices plus our offices in the District of Columbia, Puerto Rico, and the Virgin Islands, all moving one or more pieces of legislation to support family caregivers. And these are the categories that we're working on. Providing support to family caregivers during hospital transitions, and I'll talk a little bit more about that in a minute. Removing barriers to practice and care. This issue is really related to nurse scope of practice changes so that nurses can be able to perform up to the greatest extent of their education and training. And also for nurses to be able to delegate certain tasks to home health aides. Just a personal experience of mine, my father was 90 caring for my mom who was 85 at the time. She needed to have a respirator. Under the New York state laws, the nurse could teach my father how to work the respirator, but the law actually prevented them from training our home health aide from performing that same task. Those are just examples of how family caregivers need that kind of support, and if our professional licensing and nurse delegation rules aren't changed, it could provide another kind of burden for families. Respite care, it's a huge issue in this country. Many family caregivers provide 24/7 care for their loved ones. They need to take a break, and so we're pursuing respite care funding for those individuals to be able to take that break or have somebody come in to spell them while they can go to those medical appointments or get their hair cut or do the grocery shopping and not have to worry about leaving their loved ones without any kind of support while they're out of the house. Workplace flexibility, and I talked a little bit about this issue, but just to say our advocacy in the states are to try to, where it's politically feasible, of course, advance paid and unpaid sick laws. We've had some great success this year, in fact, most recently in Oregon, that just passed paid sick leave through the state legislature, and the governor's committed to sign. But again, more than half of the people in this country who go to work have no paid or unpaid sick leave. We are also advancing a few ideas that are taking hold, which are efforts to allow people to change and to take their sick leave that they have and use it for a family caregiving purpose. Remarkable as it is, laws prevent them from taking sick leave for anything other than their own illness. Now laws are changing across the country to allow sick leave to be used for family caregiving. The next category is around, which may be a bit arcane to some, but just so incredibly important. We're advancing a uniform guardianship law across the country and a uniform power of attorney law. And what this will do is, many of you may know, families often find themselves, some do, in the position of having to take guardianship to be able to perform various functions on behalf of their loved ones when they can no longer perform those functions for themselves. One example that I'll give you, and it's got a happy ending, so hang in there with me, but one of our volunteers at AARP, actually, her brother was in a motorcycle accident. She had guardianship for him in California, but she was now living in Wyoming, and she wanted to move him closer to her in Wyoming, though when she found out that she would have to go through the whole legal proceeding again to get guardianship in Wyoming, the estimated cost to her was $30,000 to $50,000 to do so. So she became our leading advocate to pass the uniform guardianship law in Wyoming, so that there'd be reciprocity, that if guardianship is acknowledged in one state, it wouldn't require family caregivers to actually seek that guardianship in another state. The same is true for power of attorney, which normally is over financial functions that family caregivers take on behalf of their loved ones. The final category is around access to direct care workers, and it's an idea to create registries of home health aides, and mostly, I think, in my experience, even in a state like New York, it was so difficult for our family to be able to find anyone to be with my parents that we could pay as a home health available help in their communities who are licensed, bonded, insured, are cleared of any kind of fraud or criminal record. And I'm pleased to say that in Montana this year we got that bill passed, and the governor's committed to setting that registry up for the first time through an administrative action of an executive order. We hope to see that more and more. You know, many Medicaid offices actually do all the screening for providers in the state, but that information is not publicly available to family caregivers. So it's a kind of a simple way to share that information so that everyone can have the peace of mind the people that they're retaining actually have the credentials they say they have, and the legal support along with it. I want to talk a little bit today about the CARE Act, and I'm so appreciative of the opportunity. I will just give you a quick overview first, though, of our progress this year. So in the legislature this year, we have enacted or passed one or more pieces of the legislation that I have just mentioned through 25 state legislatures. And we're still going. So we still have about 14 states in session. But it's been gratifying to see how widely bipartisan the support has been for these provisions. And we're making progress, but more to do. And that brings me to the topic of how we got to creating the CARE Act. My colleague and friend, Dr. Susan Reinhardt, who heads our Public Policy Institute, co-authored a report several years ago called Home Alone. And that report is available on our website, but it found a couple of things. It found that 50% of family caregivers were performing complex medical tasks that at one time would only have been performed by nurses or health professionals at home on behalf of their loved ones. The report found that most people didn't receive any training to perform those medical tasks, and remarkably, 69% of care recipients didn't receive a home visit by any health professional post-discharge from the hospital. 51% of family caregivers identified those complex medical or nursing tasks that they were performing at home were also preventing the institutionalization of their loved ones. So we've got family caregivers who really are the backbone of the healthcare system that prevents really unnecessary institutionalization, very costly nursing homes. Where, by the way, when we poll people time and again at AARP, 90% of Americans tell us that they want to live in their own home in the community for as long as it's safe for them to do so. Family caregivers allow that to be possible. And 50% of family caregivers reported feeling depressed or even hopeless at times, for sure alone in this caregiving duty. So AARP crafted something called the CARE Act. The CARE Act is the Caregiver Advise, Record, and Enable Act. It does 4 things. It, for the first time, will require that whenever a person is admitted into the hospital, that the name of the family caregiver would be recorded in their file at the time of hospital admission. What's powerful about the CARE Act, I think, is that this is not age-based. It applies to anyone. And the person being admitted is the one in control who can designate who they would like to have in that hospital file. Could be a couple of people. But the precedent that's been set by the CARE Act here is that the involvement in the family, in the case from the start of the case, is critical here. The second piece here is adequate time for notification prior to discharge. I can't tell you the number of town hall meetings I've been in where people have recorded that, they got a couple of hours notice prior to discharge of their loved ones. That's not adequate time for people to get prescriptions changed, for people to get their home in order, food in the refrigerator, medical equipment ordered, and so forth. There is an expectation that there be a consultation with the family caregiver on the discharge plan and assessing what the caregiver may have by the way of supports in the home. But I think probably most importantly, the last piece is what we've talked about is training, but actually it's just a simple instruction. So prior to discharge, there'd be a simple instruction of the wound care you'd be asked to perform, or we hear of people who are doing feeding tubes and pick lines, and no one shows them how to be able to perform these functions. And then when they leave the hospital, they're clearly home alone. So that's the CARE Act. The CARE Act has really caught on, and I think in many ways it's because it makes good sense. And so far, and by the way, Maine, apologies for this chart, because just a few days ago, the Maine state legislature passed the CARE Act. So since last year, when we had two states, the first state of Oklahoma was the first to enact the CARE Act, then New Jersey. Since that time, 15 additional states have passed the CARE Act this year, and it's pending in several state legislatures across the country. In fact, last night, Puerto Rico just passed it through one house. And in what we hope the CARE Act will be is the beginning of a conversation. Please don't get us wrong or me wrong that the CARE Act is the silver bullet or the biggest change that we need to make. But we know that 1 out of every 8 people on Medicare who leave the hospital return to the hospital in 30 days in this country. We know that the experiences of family caregivers are such that they're afraid of making mistakes in the care of their loved ones. And we hear this testimony time and time again. We're hoping that the CARE Act is the start of a conversation of how to provide those greater supports for them after they come home from the hospital, so they can have the peace of mind that they know what they're doing. I will tell you, and you certainly probably have heard it yourself or experienced it, it's a very scary time. And people will say, oh, well, in the hospital, we do that already. Well, in fact, it doesn't occur in every hospital for every patient. Many people are handed just a dizzying array of instructions and are told that it's time for discharge. We're not blaming anybody in the hospitals. They do the best they can, but we need to do better than we're currently doing for everyone to have that same experience. I will just tell you a bit about the Oklahoma CARE Act and how it actually took hold. Actually, one of our lead volunteers and advocates were the Mercers. And Doug Mercer had returned to Oklahoma after 3 tours of service in Iraq. He came back thinking that he was starting his new life at home with his wife and kids, took off on his motorcycle and went out for a ride, got into an accident. That accident landed him into the hospital. And after numerous surgeries, his wife was moving him from their truck into a wheelchair to get him into the home, and broke his leg. And the fact is that no one had instructed her how to safely transfer him from a car to a wheelchair and so forth. They became our lead advocates. It's a simple law that can make a big difference in people's lives, and we're just so pleased to see it taking hold. And even more, in May I was in New Jersey, and just a shout out to the New Jersey Hospital Association, who had already trained their hospitals and had changed all of their intake screens to include the name of the family caregiver and to include those kinds of instructions on behalf of family caregivers in New Jersey. And we're hoping that people now will take advantage of those new laws. We set up a website just like the Mercers, and their stories are really roadmap to reform. So we encourage you and everyone to check out our website, aarp.org/iHeartCaregivers. On there, you'll see personal stories from people around the country who are sharing their caregiving stories and their stories specifically around some of the changes they'd like to see in their state. There's an interactive map where you can click on the state, then see what are the caregivers talking about, what are the kinds of areas for reform they'd like to see, and then you'll be able to see a drop-down menu in those 6 categories that I outlined of those stories that will actually help to bolster our efforts to move this agenda forward in states across the country. In addition to this, AARP has a website, aarp.org/caregiving, and on that site, it has an interactive site with a vast array of information, from financial issues to legal issues to medical issues to chat rooms to any number of tools that family caregivers might need in their journey of caregiving. You'll be seeing in the next several months and through next year more concerted outreach that we're doing in multicultural communities that we're already active in, but to help give those families the support they need that may face unique challenges in the systems they're navigating in their own communities. So stay tuned for more information as we move forward. I will have to acknowledge finally that to celebrate the champions that have emerged in state legislatures. Last year, AARP launched something called Capital Caregivers. It's an award to elected officials who are standing up and either sponsoring or advancing legislation and program changes that will help support family caregivers. There's just a growing sense that these are not Republican issues or Democrat issues, but they're family issues, and the power, in my experience and my true delight to have had the honor of working in public policy and advocacy for my career. When you see issues where people see themselves in those public policy issues, there's a power to make a change in this country. People can do it in their own words. It takes leaders to lead, and AARP wants to support those leaders who are making a difference on behalf of the 42 million family caregivers who may be without a voice, may feel isolated, but know we're on the job for them. So with that, I thank you so much for listening to my presentation and look forward to any questions you may have.
Well, thank you so much, Elaine, for a fantastic presentation. This is Amy Gibson, COO at the PCPCC. As we wait for some questions to roll in, maybe we can talk a little bit more about the work AARP is doing in this area and some other advancements that we're seeing as it relates to integrating family and caregiver involvement in primary care as well. Just a quick reminder to everyone that we don't do audio questions on our webinars, but if you want to go ahead and send in your comments or questions, even if you want to let us know about what your organization is doing in this area of work. Please do type in your comments, and I will be reading those off to Elaine for the next few minutes as we have time for some Q&A and some further discussion. So I'm really excited by the work that you're already doing, and I think you kind of hit the nail on the head, Elaine, when you said, you know, this is not necessarily the silver bullet, but it's a good first step on the pathway to ensuring that we really do not just, you know, provide information to caregivers, but also really engage them in the care of their family member or loved ones. I think that that's one of the big areas that we're really pushing for here at the PCPCC, is that we really meaningfully involve everyone who's part of that family and that patient in the support of that patient as full and active members of the care team. So from the minute they're admitted to the hospital or even in the primary care setting and in the community, I mean, this is where kind of the rubber hits the road. You know, you're only in the hospital for a limited period of time, but so much of what goes on in the ongoing support and care happens in communities, and how do we really effectively transfer all this information to everyone who's involved in that individual's care. So I don't know if, Elaine, you want to talk a little bit more about some of the other work that's going on in that arena, or, you know, even as it relates to how we can be stronger and better advocates in lots of different areas, because again, it's not just what happens in the hospital, but it's in all areas of the healthcare system.
Well, thanks for that question, and I would just say a few things. The recognition of family caregivers as a part of that care team just is essential. And of course, the family caregivers may come in and out of that family's case. So in my case, my father was there for my mother was there for my father, but my brother and sister and I would cycle in and out of that family. And frankly, we played different family caregiving roles on behalf of our parents. And so I think it's recognizing that dynamism of families. I think also the recognition of a growing cohort of people who need family caregiving and respite. Our military family caregivers who are facing unique challenges as we're welcoming back those that have sacrificed so much for us. They're often coming home with serious injuries and at a very young age. And so the knowledge of those resources from military families is something that we also want to expand. You know, it's hard to put the pieces together. Where do VA services, where does health insurance, where do other state services intersect on behalf of those families? We're also seeing, of course, the phenomenon of perhaps medical achievements that have people with disabilities who, as children, had their parents take care of them. Now we're seeing that their parents are aging and they're passing on. So what happens for those children who are now adults? What does that caregiving arrangement look like, and what can we do to support their needs? So we're also very interested in working in the area of telemedicine, in closing the gap for family caregivers through technologies, and really modernizing the way care is delivered. So if you can FaceTime with someone when you get a new pet, and they can show you that, why can't we be using FaceTime for conferencing in family caregivers into those medical appointments, so that we can take all the technology we have that are simple to be able to make and draw those connections. So you'll see us moving more into helping to fit the telemedicine issues more into the lens of what it can do to empower family caregivers. And then, finally, I would just say that the other piece that I think is key is we're very excited and have been for a couple of years with open notes, a movement to be able to share the notes that medical providers write in those medical charts with not only the patients, but also with permission, of course, to their family caregivers. In my personal experience, if I really had that continuity of understanding what was going on with my mom, I think I could have been a better caregiver if I understood the full extent of her condition. Clearly, my father, God bless, who was up front and up close to her every day, couldn't keep track of all of those conditions. With a little help, we all could have been part of that care team. So technology, transparency, and also realizing that this isn't something just for people who are 50 years of age and older. This is as much for parents who are caring for children with disabilities, military families who are dealing with the aftermath of serious injuries, and more. So kind of expanding our thinking and expanding that net and acknowledging at last that family caregivers are probably the biggest part of our health workforce. How can we include them in those conversations?
Yeah, I couldn't agree with you more, Elaine, and I really appreciate you talking about all the different opportunities, whether it's through new technology, through electronic health records, all these different ways that we're starting to create some new strategies to deliver care in a different way. And so a lot of what we talk about the PCPCC is how do we kind of align the needs of the patients and families with new technology and new models of care delivery, and then also creating different and new incentives and ways that we can really drive that change and make all of this kind of come together and happen. So we've gotten some great questions that have come in, and some of them are around that payment piece and new models of care, like ACOs. We have new CPT codes for care coordination, care management. Can you talk a little bit about AARP and the work that you're doing, if any, in that particular area, and how you're looking at helping to align some of these new kind of payment models and incentives that really drive that change toward involving and supporting caregivers?
Sure. It's a great question, and I think that, frankly, in the ACO model, we're very involved, and we're very involved in also provider payment reforms. I certainly have spent in my career probably 15 or 20 years in Medicaid. So I think it's important for us to think about ACOs and MCOs and now managed Medicaid long-term care in the states more holistically. Because I think you have ACOs that are creating one model of system of care, you've got MCOs that are creating others under Medicaid, and now brand new types of capitation and provider payment reforms and Medicaid managed long-term care. And so how can we think more strategically about getting the incentives right in all of these systems so that we're valuing the same things? Care coordination is just so critical. What does it also mean for people who are not so chronic, so that there's a prevention component in their provider reimbursement? And there's got to be a win-win in the system so that people don't become, as they say, truly dually eligible for Medicare and Medicaid because their conditions have become so chronic that they qualify for both. So what can we do in thinking more from a prevention standpoint of how we can change and prevent people from their health conditions getting to be so deteriorated in the systems that they're in. And so, I'd love to see fewer silos between Medicare and Medicaid. That's always been true. But also fewer silos between Medicaid, Medicare, and private insurance. What can we do to get those hydraulics right so we're really transforming that system of care with the patient and the family at the center? I would just mention one other kind of piece is that, we're still fighting to try to get family caregivers into any of these models because they're pretty much invisible in the design of these payment systems. So much more needs to be done in that respect.
Absolutely, and I think things are changing on that front. I mean, we've certainly seen patients and families getting more involved on the Medicare side of things as they're trying to start to enact what's in the new legislation around how physicians are paid. Through the Learning and Action Network, we've seen some addition of patient and family advocates to that. So I think people are starting to understand and appreciate why, even when we're talking about payment models, that it really is critical to involve patients and families in the development of those programs as well. So absolutely. A couple other questions have come in, and this is not surprising, about HIPAA. So when we talk about sharing information with individuals who are not the patient and maybe not even their marital spouse or someone who's formally part of the family but is a critical member of their care team, is truly their caregiver. Can you talk a little bit about additional education that might be needed on that front? Is HIPAA truly a barrier on that front, and are there things that need to be changed as it relates to sharing information?
It's a great question, and actually we looked at the CARE Act, for example, and brought it through the whole HIPAA test of where HIPAA begins and ends, and clearly, I think HIPAA, remember, it was passed how long ago, right? I mean, it was passed in a very different time, and
right.
And I think that also HIPAA has been interpreted in certain systems as a real barrier to preventing any sharing of any information, which, as you know, is not the case.
Right.
So part of it is not to educate everybody on HIPAA, but help the system to understand that that HIPAA isn't, the barrier. I was talking to a colleague the other day about our efforts that we're putting together in kind of telemedicine and thinking things through. Well, of course, what's going on in certain MCOs in sharing information on patient records through websites, through with permission to parents of children, to there's an evolution, a transformation that's going on in technology that in many ways, HIPAA is almost outdated, in terms of it never anticipated this kind of movement. And so is it another time to take a look at HIPAA? And if so, is it being used as a barrier for involvement or an important protection? I think it's just worth thinking through what the next stages of HIPAA might be.
Yeah, I completely agree, because again, the intent of the law was to make sure that there were certain and important, protections in place, but certainly was never intended to keep any important caregivers out of the care of their loved one and the support that they all need and the important roles that they play. So I think as
and remember,
kind of
even
final,
back in the day,
go ahead.
I'm sorry. Remember, even back in the
That's
day, HIPAA was about portability.
Right, exactly.
And then it kind of
information, yeah.
Right, and then it kind of grayed into privacy. And
yeah,
so,
yeah.
I think we need to kind of rethink I'm not suggesting that that we look at legislative changes, but certainly interpreting it given where the health systems are now would empower patients and caregivers.
Most definitely. So I think as a final question, we've got one from Marcy. So Marcy, did you want to kind of wrap things up with Elaine with some final comments and questions for her?
I do. Thank you, Amy. Amy can hear me sort of chomping at the bit to ask this final question, and that is, I do want to make sure I underscore the terrific report that Susan Reinhardt published in 2012 that Elaine mentioned earlier, called Home Alone: Family Caregivers Providing Complex Chronic Care. And she, in this report with her colleagues, outlines a number of recommendations that link back to some of the things that we've touched on but not overtly talked about, and that is how we train a new set of health professionals, or the current health professionals who take care of the chronically ill, to include patients and families and caregivers in more overt ways. And that's challenging given how many of them struggle with just taking care of the patient's clinical needs. We're now asking them to be very mindful of behavioral health needs. We're asking them to be aware of social needs, and now we're saying, and let's also include the family and caregivers in this dialogue. But Elaine, to your point, if we don't, these individuals go home and are cared for by a family member or a caregiver who's unable to actually provide care to them. Can you cite any work that's going on the training front, whether that's changing standards or just trying out new programs, whether it's in an academic health center or it's sort of out in practice? Who's doing a good job of training the workforce of tomorrow to be mindful of the inclusion of families and caregivers?
Well, you know, it's so it's a great question, and I want to say that once again, Susan Reinhardt is on this one and is actually putting together a new overview of promising practices in family caregiver training. Where and that not only should be coming out in the coming months, but she is also advancing a series of training videos that could be used to kind of train the family caregivers on these kinds of medical tasks, or even having the conversation. You know, I think that it could be as complicated or as simple as people would make it. And I just want to say the health professionals I experienced in caring for my parents were just fantastic. And I appreciate the struggles and the issues and demands on their time. I think the power here is in whether or not the providers and the system can actually see family caregivers as part of that team. And if so, it's not someone to have to assess and to care for, but it's someone who can help assist and to gain information from. You know, I'll just say that that please continue to check out the great work of our Public Policy Institute. Susan Reinhardt has a number of reports and studies that will come out in the next several months around these areas. A real tool and a real contribution, I think, to keep the conversation going, and even more to provide that kind of best practice view of what's going on in hospitals across the country and in health.
Well, and one quick follow-up question, Elaine, because the AARP resources are terrific. But a question I got asked at a meeting where I was this morning, and a terrific suggestion from a gentleman who not unlike you has been a caregiver himself, was, is there a place to go to get peer support from other caregivers? When you've been diagnosed with an illness, there are disease advocacy organizations that provide a lot of information and often connect you to other patients. Is there something similar that exists in the caregiver community, whether it's at AARP or maybe some resources outside of AARP that provide that kind of peer support?
Well, thank you for asking that. In fact, on our website, aarp.org/caregivers, there is a caregiving rather. There is a telephone number and link to a variety of caregiver support organizations. And if you can't get them through the web, you can get a telephone number where you can start making the connection. I will tell you that there probably are more, disease-specific caregiver support organizations than a more generic one. But I will say that they're growing in terms of people creating opportunities for caregivers to share with other caregivers about their experiences, and so please check out our website and learn more about that.
Terrific. And one final plug for AARP that I would make is that while it is true there are a number of resources online, the work that Elaine is doing and many, many others that is state-based is also a terrific way in which to get linked to AARP's activities on a local level. And a shout out to my friend David Wilson, who runs the Kansas AARP. I worked with them very closely when I worked at the state level for folks who are interested in getting more active with AARP at a grassroots or local level.
Well, thank you for that. And in fact, if you're interested in linking to your state AARP office, you can go on to our website, just aarp.org/ and then just write in the name of your state, and it'll take you to our state. And some of our states now have local and community websites, but also resources to link up on the ground with them. And please, if you feel like any of these issues resonate with you, please share your stories, share your time. We could use your voice in state legislatures across the country.
Terrific. Well, I'd like to thank Elaine one more time for joining us for all of this terrific information, obviously for the very important work that you're doing. Thanks to Amy and Marcos and the rest of the PCPCC team. Thanks to the United States Supreme Court for upholding the Affordable Care Act, and thanks everybody for joining us today for this webinar. We appreciate it.
Thank you.
Bye-bye.